All right. So I am delivering a tutorial on postoperative nausea and vomiting. And so that's the tutorial I'm doing today, and that's me, Dr. Lidwa, with the credentials. So a couple of questions that I had encountered just in the past papers when I was prepping for this topic was questions like name the 5 classes of your antiemetics that can be administered in the perioperative period and give an example of each class. We'll revisit these questions at the end. And then you're giving a scenario, and then they ask you to list 4 patient factors that may predispose the patient to postoperative nausea and vomiting. Right, so just to give you guys an outline of what we'll be talking about. So first we will go through some important definitions, and then we'll talk about the physiology of vomiting when we look at risk factors and some of the adverse effects of vomiting, and then we'd look at different scoring systems that are used for postoperative nausea and vomiting, and then the classes of drugs that are used and risk stratification for these patients. All right. So some important points on like postoperative nausea and vomiting is that nausea and vomiting in the postoperative period occurs in approximately 20 to about 30% of patients. The majority of the patients list vomiting as the most undesirable effect of nausea as the fourth most undesirable effect of anesthesia. So recent studies have shown that PONV is more prevalent in the Caucasians more than the Black population. I think it's mostly due to some genetic factors that the Caucasians would actually have versus the Black population. Then some of the important definitions that I think we all should know, things like your nausea. So nausea is an unpleasant sensation in the upper epigastrium with an inclination to vomit. Then when you've got wrenching, so wrenching is basically labored spasmodic rhythmic contractions of the respiratory muscles without expulsion of your gastric content. And then with vomiting or emesis, this is the forceful ejection of your gastric content via the mouth. So then this is important, but we also need to know what's the entire process that takes place for you to have this vomiting or the physiology of vomiting itself. So the physiology of vomiting is basically a 3-stage process. You get an input. So your input can come from different sources, which we will be exploring in the next couple of slides. And then this thing needs to be processed in the brain, and then the brain will send out an output, and then you then start vomiting, which is now the output reflex. So the input comes from 3 different sources. So it's basically your central nervous system, your gastrointestinal system, and your chemoreceptor trigger zone. Your chemoreceptor trigger zone is the most important area that we focus on in terms of anesthesia. You will find out why we actually focus on in the next couple of slides. The gastrointestinal tract as well is some of the input. Some of the input does come from there. So patients that are getting like abdominal surgeries, that are getting stretching of their abdomen, those patients are actually predisposed to having postoperative nausea and vomiting. So the chemoreceptor trigger zone is basically an area in the it's located in the area postrema of the medulla. It sits outside the blood-brain barrier, which makes it predisposed to any drugs to actually reach it, because we all know that our drugs need to cross the blood-brain barrier before they cause its effect, or they exert the effects on any in the brain. So some of the actions of the anesthetic drugs are actually found in the chemoreceptor trigger zone. So receptors that are found in this chemoreceptor trigger zone are your acetylcholine receptors, which is mostly your muscarinic receptors, your dopamine receptors, which is your D2, your serotonin receptors, which is your 5-HT3, your neurokinin receptors, your opioid receptors, and also your histamine receptors. And then the vomiting center, what's special about it is that it's close to the nucleus truncus solitarius and certain autonomic nuclei. It's believed to have almost 40 neurotransmitters that are implicated when it comes to its neurochemistry, but five are believed to be important when it comes to postoperative nausea and vomiting, which would include your acetylcholine, histamine, serotonin, dopamine, and substance P. So majority of the drugs that we actually use antagonize these substances through a central effect for the postoperative nausea and vomiting. So how do we then get this output? So the output is predominantly vagal inactivity. I'm sure you've all noticed when patients are about to vomit, they become bradycardic, or when they start insufflating the stomach and you're suspecting that they're going to vomit, they first become bradycardic. So it is a vagal activity. So what generally happens is that they get the vagal activity, then they have salivation, then they get the relaxation of the lower esophageal sphincter, which causes cessation of breathing, causes a contraction of the stomach, causes a contraction of the abdominal wall, and then it causes a contraction of the pharynx, and then you get projection of whatever abdominal content that the patient currently has. So this basically ties it all up. I don't know if you guys can see the arrows properly, but all our um, all our inputs basically diverge to one area, which is either your cumulative trigger zone and also your vomiting center. Even in the cortex, it goes back to the vomiting center. So these are the two important areas that we need to target, especially if we want to give our drugs for postoperative nausea. So some of the important risk factors, you basically divide them into three. So you've got your patient risk factors, anesthetic factors, and also surgical factors. So your patient risk factors, if it's a female patient, a non-smoker, previous history of postoperative nausea and vomiting, motion sickness, and if they are between the ages of less than 3 and more than 50. And then the anesthetic factors, if they have prolonged fasting, which is now slowly being removed. And we all know that the SASACA fasting guidelines are very strict with regards to what type of fluid these patients should get when it comes to your fasting period. The use of volatile anesthetics, the use of nitrous oxide, etomidate, opioids, neostigmine, hypertension, and hypoglycemia have all been believed to be anesthetic risk factors towards postoperative nausea and vomiting. Surgical factors, your strabismus surgery, your middle ear surgery, tonsillectomy, laparoscopic surgery, gynecological surgery, abdominal surgery, and also oculopexies. Those are all believed to be risk factors towards having postoperative nausea and vomiting. Then again, just from emphasis with some evidence behind it. So this is taken off from the post-operative nausea and vomiting general consensus guidelines that looks at the risk factors for post-operative nausea and vomiting in adults. I think most of the risk factors, we did mention them in the previous slide, but some of the disproven or limited clinical relevance are those with patients with high BMI, patients that are anxious, and then the perioperative fasting as well is slowly becoming disproved. Then when it comes to the scoring system, so whenever we have these patients that you think are at high risk of having, or whenever you have a patient that you think this patient might have postoperative nausea and vomiting, you look at their risk factors. So there's a scoring system called the Apple score. It's easily available. You can literally calculate for each risk factor. So once a patient has one risk factor, so that they have a percentage risk of about 20%. So the risk factors that are implicated is if a patient has a female gender, a non-smoker, has a history of postoperative nausea and vomiting, and there's also a use of postoperative opioids. So once a patient has 1 point for each of the risk factors accounts for 1 point. Once a patient has 1 point, it says it's equivalent to about 20% risk of having postoperative nausea and vomiting. Then on severity, that's 2 points, it's about 40%. So it's almost like double the amount of the number of risk factors. Then again, we've got the Covenatra score, which is slightly similar to the Apple score, with just in addition to the age. So again, female gender, history of post-operative nausea and vomiting, age of less than 50, the use of opioids in the PACU, nausea in PACU. So those are the risk factors. Again, similarity, if there's 1 point, it's about 20%, 2 points is almost close to about 40%. It doesn't just end there. Pediatric patients also have a scoring system of their own. So it's called the EBA-HOT, which is basically you look at the type of surgery. If it's a surgery is lasting more than 30 minutes, if the patient has an age of more than 3 years, if it's a strabismus surgery, and also if there's history of postoperative nausea and vomiting. Again, the percentages are almost the same as adults, but what's been proven is that the higher the amount of points for pediatric patients, the more the risk. And then with the pediatric population in terms of management, so you risk stratify them according to the risk factors. So in the preoperative period, you look at the age, if it's more than 3 years, the history of postoperative nausea and vomiting, and if there's actually a family history, and if they post-pubertal females. And then in the intraoperative period, you look at if they've got strabismus surgery, tenotonsillectomy, otuloplasty, surgery of more than 30 minutes, the use of volatile anesthetics. And then you risk stratify these patients according to their risk factors. So if there's no risk factor, then they become a low risk. But if there's one or two risk factors, they become a risk. And if there's more than 3 risk factors, they become a high risk. So then what do you do when you stratify these patients? You then have to treat them prophylactically. So if it's low risk, you can only give a serotonin antagonist or just dexamethasone on its own. But if it's a medium risk, you have to do a combination therapy. So this is the one time where we actually advocate for a multimodal approach in terms of these post-operative nausea and vomiting drugs. So it's been proven that your serotonin antagonists with the combination of dexamethasone are very effective in terms of preventing any post-operative nausea and vomiting. And if they're high risk, you have to do your serotonin antagonist with your dexamethasone, and also have to consider performing a total intravenous anesthesia for these patients. And then some of the adverse effects. So patients do get patient distress and dissatisfaction. You can get a pulmonary aspiration, since some of these patients might have issues in terms of their airway reflexes. They do get postoperative pain, which is an issue because if they have an abdominal surgery and they're now wrenching, causing abdominal contraction, would be an issue. That have wound dehiscence and hemorrhage, especially the ear, especially patients that are having eye surgery, head and neck, and also they can also have an esophageal rupture. They can have dehydration and actually electrolyte disturbances, and that would actually require IV fluids. They can also have a delayed oral intake, especially if you've ordered oral drugs, and also in terms of their nutritional status, that have a delay in terms of starting feeding. That have delayed mobilization since their electrolytes would be abnormal, and that could actually lead to having them having a delayed discharge in the ward. So then how do we actually prevent this postoperative nausea and vomiting? So it's basically divided into two. You've got your general measures, and then you've got your pharmacological measures. So your general measures is basically you avoid prolonged fasting periods, you have adequate hydration, you decide on your anesthetic technique, if you're performing a regional technique or a total intravenous technique or volatile anesthetic, but avoiding the use of nitrous. You have to inquire about any previous histories of postoperative nausea and vomiting, and then you actually have to re-stratify your patient so that you can tailor your anesthesia towards this patient stratification. And then strategies to reduce basically the baseline is things like avoiding GA and using regional anesthesia, the use of propofol for induction and maintenance, avoidance of nitrous oxide, avoidance of volatile anesthetics, minimization of intraoperative and postoperative opioids, so push for multimodal analgesia, adequate hydration, and the use of sugammadex instead of neostigmine. And then in terms of pharmacological measures, so we will be covering the following classification of the following classes of drugs that are used for covering these patients for postoperative nausea and vomiting. So we're looking at your dopamine antagonists, your antihistamines, your anticholinergics, your serotonin antagonists, your neurokinin 1 antagonists, and then other classes which include your midazolam, propofol, corticosteroids, and cannabinoids. So in terms of your dopamine antagonist, the one drug that is always mentioned is your droperidol, which is basically a D2 receptor antagonist with a low affinity for alpha-2 receptors. So it also has some affinity for histamine 1 and serotonin receptors, and it is as effective as the enzotron, which is a serotonin antagonist. It's mostly used for anti-nausea more than antiemetic, but it does come with side effect, which is your sedation, drowsiness, and hypertension. It does have a black box warning. It causes a prolonged in terms of the QT interval, so can actually lead to a torsades de pointe. So in terms of your dosage, you gave it a dose of about 0.65 milligrams, so about 1.5 milligrams in an adult. In a pediatric population, you give it a dose of 0.01 to about 0.015 milligram per kg, especially if the kids are more than 2 years or more than 10 kg. It's recommended it should be given just before the end of the surgery. So there are recommendations in terms of when to give it. Then our next drug is your dopamine antagonist, which is your metoclopramide. This has been the most effective antiemetic of its class and is used for almost over 40 years. So this one, it's an antiemetic that results from antagonism of the dopamine effect in the chemoreceptor trigger zone. It does have additional effects in terms of the antiemetic. Some of the additional effects is that it also has cholinergic actions on the gastrointestinal tract, which increases your esophageal sphincter tone and also causes facilitation in terms of gastric emptying into the small intestines. The dosage it is currently used to use about 20 to about 50 milligrams per 24 hours at a dose of 10 milligrams at a time for adults. And then the pediatric dosage is about 0.15 milligram per kg IV. The side effects, it does cause abdominal cramps, sedation, dizziness, dystonic extrapyramidal reactions, and also you can get cardiac dysrhythmias. And then your antihistamines, you've got your cyclizine and your promethazine, which is basically given at a dose of 50 milligrams orally, IM or IV. And then the promethazine is given at a dose of about 12.5 to about 25 milligrams orally, IM, and IV. It does come with side effects. So part of the side effects is that it can cause sedation, dry mouth, visual disturbances, and also urinary retention. So this is just a summary of cyclizine and how it acts. So it's a compensative antagonist in terms of the H1 and your muscarinic receptor. It's used in antiemetic and also Meniere's disease. In terms of its metabolism, it's hepatic metabolized, decreases dose. You need to decrease the dose in patients with liver failure, and also it's excreted in the urine. In terms of its effect, it's got an increase in your lower esophageal sphincter tone. It causes a tachycardia, and also it's painful in injection because of the pH. And then your anticholinergics that is commonly used is your hyoscine hydrochloride, also known as your scopolamine. It's given at a dose of about 0.2 to about 0.4 milligrams subcut, or in terms of you can give it IM 6 hourly. It's indicated in prophylaxis and treatment, mostly in motion sickness patients. Its side effects, it can cause dry mouth, blurred vision, dizziness, and also confusion. Then you've got a class of these drugs, which are called your serotrons or your 5-HT3 antagonists. So they basically act all in the same receptor, but the one that I've had experience with is your ondansetron. Ganestotron as well is available, but I'm not too sure in terms of it's available in the state. But the one that is mostly used is your ondansetron. So in terms of your serotrons, you'll focus on ondansetron in itself. So ondansetron comes in different packaging. So it does come in a 2 milligram per ml solution, which you can give almost 4 milligrams to about 8 milligrams in adults. In terms of the children and babies, you give it a dose of 0.1 milligram per kg. It has a greater affinity in controlling established postoperative nausea and vomiting. It is the first line treatment for postoperative nausea and vomiting, especially when no prophylaxis has been given. But it does have side effects, which is you can get hypersensitivity reactions, headache, dizziness, and elevated liver enzymes. Again, in your ondansetron, just a quick summary on it. It antagonizes the peripheral and central serotonin receptors. It's used for anti-emetic and it's effective in postoperative nausea and vomiting, and also induced nausea and vomiting. It is hepatic metabolized. You need to decrease its dose in terms of patients' liver failure. And then in terms of its side effects, it causes GI constipation, you get a headache, a bradycardia, and flushing. And then there's caution in patients with prolonged QT interval. You can't give it because it can push them to SARS. Then another class of drugs that we do use is your neurokinin 1 or your NK1 receptors, also known as your aprepitant. So your neurokinin 1 receptors are found in the nucleus truncus pectoris and also in the area of posterior in the central nervous system. It is an antiemetic. This antiemetic may be superior to ondansetron for prevention of vomiting in the first 24 to 48 hours. It may also decrease the INR in patients who are receiving warfarin. It's generally given at a dose of about 40 milligrams orally, 3 hourly in the preoperative period. Another class of drugs that we do use and it's easily available is your dexamethasone, which is a corticosteroid. It does have a delayed onset, at least about 2 hours. It's best given at induction, and then the recommended dosage is about 5 milligrams IV is effective for postoperative nausea and vomiting. In terms of dosage, you do use a dosage of 0.1 to about 0.15 milligrams per kg for pediatric population, and then repeat doses of dexamethasone are not recommended. In terms of the timing for your postoperative nausea and vomiting drugs, I'm not too sure if it's projecting very well, but basically your dexamethasone are given at induction, and then your ondansetron, which is the one that we commonly have, is given at the end of surgery. The scopolamine is given prior to the evening or 2 hours before the surgery. So those are the drugs that are easily available that we tend to have in theater. And then your metoclopramide is basically given during the operation. So you can give it anytime during the operation, even at the postoperative period and the patient actually has vomiting, you can give your metoclopramide. And then risk stratifying these patients. So this is basically based on the actual score that we basically covered in the previous slides. So 1% or one risk score or one risk factor puts you at 20%. And then in terms of the prophylaxis number of antiemetics, you need about 1. So you can either give ondansetron or dexamethasone for these patients. If they then have 2 risk factors, they move up to about 40%, and then you need to give them 2 drugs and also consider ondansetron and dexamethasone and also plus minus a propofol infusion. But we all remember that once they have 3, they're more at a higher risk. So those ones you can give ondansetron, dexamethasone, a propofol infusion, plus minus a scopolamine patch. So this time it's no longer a plus minus propofol infusion. You have to actually give them Ativa anesthesia. Then again, in terms of adult postoperative nausea management, you have to risk stratify them according to the risk factors, and then you have to try some risk mitigation, which is you basically minimize the use of nitrous oxide, volatile anesthetic, high doses of neostigmine. You have to consider the use of regional anesthesia. You have to consider opioid-sparing techniques in terms of these patients, and then you have to risk stratify these patients. In terms of your prophylaxis, it's basically all the drugs that we've actually covered in the previous slides. And then you can also have like your rescue therapy for these patients. This is a table that I used when I was studying. So you basically look at a couple of risk factors. So if there's a history of postoperative nausea and vomiting, and then you combine it with if a patient is a female and you're going to be using postoperative opioids and there's any history of motion sickness, long duration of the surgery, emetogenic surgery, and the patient is a non-smoker. And then there's a couple of things that you need to consider. So you need to consider the use of regional anesthesia technique. You need to have adequate hydration, avoid the use of nitrous oxide, avoid high doses of neostigmine, and also try and avoid the use of inhalational agents. If a patient has A, which is the history of vomiting, or three factors from table B or box B, then you have to consider a combination of 2 drugs, which is your serotonins and your dexamethasone. So whatever that you're giving, your anti-serotonins must be there. And then if the patient is A and then a history of postoperative nausea and vomiting, and or more than 3 factors from B, you then have to give 2 antiemetics, plus you have to consider Ativa anesthetic with propofol. So I will end there with my tutorial.